Hello, everybody. Happy New Year 2026. This is Jeanne Poole. I am the editor-in-chief of the Heart Rhythm O2 Journal, and this is the January 2026 podcast. We have a lot of papers to go through and summarize. The title of the first paper is Early Prediction of the Efficacy of Local Epicardial Radiofrequency Ablation for the Robotic Treatment of Persistent Atrial Fibrillation by Dr. Daniel Salvi and colleagues. The key findings of this paper are that first, a timely prediction of the efficacy of local epicardial radiofrequency ablation is provided to stop ineffective LERFA, which is the abbreviation the authors state for local epicardial radiofrequency ablation, within 5 seconds. Second key point, in their procedure, LERFA efficacy parameters are extracted from the first 5 seconds of time impedance curves, and a machine learning model predicts LERFA efficacy based upon them. Third, several machine learning models are compared to find out the best one. Next, amongst the tested models, random forests achieved 94.5% accuracy, 88.3% sensibility, and 97.2% specificities. Finally, their results show that the proposed approach enables a reduction in the number of completed LERFAs by 56.8% with respect to the benchmark approach. The title of the next paper is Transthoracic Echocardiographic and Artificial Intelligence-Enabled Electrocardiography Predictors of Atrial Fibrillation Recurrence After Surgical Ablation by Dr. Dylan Goings and colleagues. The key findings of this paper are that first, independent predictors of larger left atrial size, higher AI-enabled electrocardiography, atrial fibrillation, probability, and older ECG estimated age were independent predictors of post-surgical AF or atrial flutter recurrence, underscoring the prognostic value of both structural and electrical models of atrial arrhythmia remodeling. Model performance, the multimodal Cox model showed moderate discrimination with a C-index of 0.67, but excellent calibration with a 3-year Breyer score of 0.21, a 3-year arrhythmia-free survival of 85% versus 43% across the lowest and highest risk quartiles. P-value less than 1.0. These findings indicate strong calibration and clinically meaningful stratification despite modest global ranking performance. Third, model robustness, predictive performance, and key associations were consistent across surgical areas and missing data sensitivity analyses, supporting model stability and generalizability. Next, clinical implications. This model enables risk-adapted rhythm surveillance, identifying patients at higher risk of recurrence who may benefit from intensified follow-up or risk factor modification, while supporting routine care in lower risk groups. And finally, novelty and future directions. This study is the first, to the best of their knowledge, to evaluate the prognostic utility of AI-enabled ECG biomarkers in a surgical AF ablation population. Future research should focus on prospective validation and incorporation of dynamic or multimodal AI-derived imaging features to further refine prediction accuracy. The next paper is titled Association Between Non-Ablated Left Atrial Surface Area and Rhythm Outcome in Patients Treated with Cryoballoon and Radiofrequency Ablation by Dr. Moon-Hyun Kim and colleagues. The key findings for this paper are that first, cryoballoon pulmonary vein isolation was independently associated with a higher risk of atrial fibrillation recurrence after ablation compared with radiofrequency PVI in patients with a large left atrial size and those with persistent AF. Second, a larger remaining non-ablated left atrial area after PVI correlated with an increased risk of AF recurrence. Third, the additional left atrial surface area reduction by RF PVI compared with cryoballoon PVI was more significant in patients with a large left atrial size and those with persistent AF than in their counterparts. The next paper is titled, Does Obesity Affect Atrial Fibrillation Ablation Outcomes? Insights from a National Atrial Fibrillation Catheter Ablation Registry, 1-year follow-up. The key findings of this paper are that, number one, obesity is not associated with atrial fibrillation recurrence after pulmonary vein isolation ablation. In this prospective multicenter study, obesity, including across body mass index subclasses, was not independently associated with increased AF recurrence or the need for reablation. These findings suggest that ablation should not be delayed solely owing to obesity, given that waiting for weight loss may reduce long-term efficacy. Second, increased rehospitalization in class 1 to 2 obesity patients with class 1 and 2 obesity had significantly higher rates of rehospitalization. A substantial portion of these admissions was unrelated to arrhythmia recurrence or the ablation itself, reflecting the broader impact of comorbid conditions. Third, procedural safety maintenance. Peri-procedural complication rates were low and comparable between groups, supporting the procedural safety of AF ablation across all obesity categories. The title of the next paper is Sex Differences in Procedural Characteristics, Safety, and Clinical Outcomes of Pulsed Field Ablation of Atrial Fibrillation. The background for this study is that previous studies on PVI for the treatment of atrial fibrillation using conventional thermal techniques have shown inconsistent sex-related outcomes. Pulsed field ablation is a novel energy source offering myocardial selective ablation. However, sex-specific data on its performance are limited. The objective of this study, according to the authors, was aimed to compare procedural characteristics, safety, and clinical outcomes of PFA in female and male patients undergoing AF ablation. This is a prospective study that included consecutive patients with paroxysmal or persistent AF undergoing PFA-based PVI using a Pentas-blind catheter. Follow-up was conducted at 3, 6, 12 months. A 1-to-1 propensity score matched cohort was created to evaluate sex-specific outcomes. There were a total of 425 patients, of which 32% were women. Compared with men, women were older, more frequently had paroxysmal atrial fibrillation, and had lower rates of coronary artery disease. Although overall procedural times were similar, female patients with paroxysmal AF had significantly longer procedure, left atrial dwell, and fluoroscopy times than males. Complication rates were comparable, 1.5% in women versus 0.7% in men. After propensity score matching 133 women to 133 men, arrhythmia recurrence at 1-year follow-up was higher in women, 23% versus 12%, with a p-value of 0.017, hazard ratio 2.2. The authors conclude that significant sex-related differences exist in clinical outcomes after PVI with PFA and atrial fibrillation, and that further studies exploring underlying mechanisms and tailoring approaches may enhance outcomes in female patients. The paper that is up next has a title of Socioeconomic Status Does Not Influence Quality of Life and Mood Outcomes After Catheter Ablation for Atrial Fibrillation, a call for equitable access. The first key finding is that the interaction between socioeconomic factors and patient-reported outcomes after atrial fibrillation ablation is not well understood. Second, cultural and linguistic diversity, education, income, and social support isolation were assessed as a single composite socioeconomic status, SES score, in a cohort of 159 patients after participation in randomized controlled trials of catheter ablation. Next, these SES factors were not significantly associated with post-ablation quality of life or positive changes in depression and anxiety scores. Next, regardless of SES status, all participants had a greatly reduced AF burden, which may explain improvements in mood and quality of life. And finally, these results support greater access to catheter ablation for AF across all SES strata. The title of the next paper is SGLT2 Inhibitors and Risk of Atrial Fibrillation Recurrence After Catheter Ablation, a systematic review meta-analysis of observational studies by Dr. Marco Zwin and colleagues. The first key finding is that treatment with SGLT2 inhibitors was associated with a substantially lower risk of atrial fibrillation recurrence after catheter ablation, corresponding to an approximate 51% relative risk reduction compared with patients not receiving SGLT2 inhibitor therapy. Second, the observed benefit remained consistent across multiple sensitivity analyses and was evident in both diabetic and non-diabetic populations, as well as across different ablation modalities, radiofrequency and cryoballoon, suggesting that the antiarrhythmic effect of SGLT2 inhibitors may be independent to glycemic control or procedural technique. Finally, meta-regression analyses identified age, female sex, and diabetes as significant predictors of atrial fibrillation recurrence, whereas longer follow-up durations were inversely associated with recurrence risk, collectively accounting for more than half of the observed heterogeneity across studies. The title of the next paper is Atrial Fibrillation Detection Performance of an Insertable Cardiac Monitor, Results from an Assert IQ Post-Market Clinical Study and a Novel Artificial Intelligence Algorithm by Dr. Ulrika Birgersdottir-Green and colleagues. The first key finding is that the Assert IQ Insertable Cardiac Monitor demonstrated high sensitivity in detecting atrial fibrillation and provided accurate quantification of AF burden. Second, the artificial intelligence algorithm substantially reduced false positive AF episodes from the ICM device while fully preserving sensitivity. And third, the AI algorithm notably improved positive predictive value, particularly for device-detected AF episodes of shorter duration. The next paper is titled Combined Assessment of Non-Alcoholic Fatty Liver Disease Fibrosis Score and B-type natriuretic peptide for Predicting Atrial Fibrillation Recurrence After Catheter Ablation, a multicenter study by Dr. Kyoko Koyama and colleagues. First key finding is that among liver fibrosis scores, only the non-alcoholic fatty liver disease fibrosis score predicted atrial arrhythmia occurrence after catheter ablation. Second, this NFS score showed a weak but significant correlation with right atrial volume, suggesting its link to right heart remodeling. Finally, combining NFS with B-type natriuretic peptide improved risk prediction and identified patients with a recurrence that was highest, which was confirmed in an independent multicenter cohort. The title of the next paper is Identifying Independent Risk Factors of Mortality Among Patients Receiving a Leadless Pacemaker, a longitudinal retrospective study in a single center by Dr. Shreya Srivatsa and colleagues. The first key finding is that in hospitalized patients, a Charlson Comorbidity Index, or CCI, of greater than 4 distinguishes a cohort having a high 30-day mortality after undergoing implantation of a leadless pacemaker for symptomatic bradycardia. Next, 3 independent risk factors were found to be associated with the highest mortality risk: age greater than or equal to 80 years, left ventricular ejection fraction equal to or less than 35%, and hemoglobin of equal to or less than 12 grams per deciliter. Third, their study concludes that despite previously described advantages of leadless pacemakers, including ease of implantation and a decreased risk of pocket and lead complications, identifying those with a higher 30-day mortality after implantation based on CCI, age, LVEF, and anemia may help in shared decision-making to avoid procedures that fail to benefit the patient while adding to the cost of care. The title of the next paper is Contemporary Practice about Cardiac Implantable Electronic Device Infections Prevention, a French multicenter survey by Dr. Antoine de Costa and colleagues. First key finding is that despite multiple practice guidelines and consensus documents on the prevention and management of CIED infections, along with multiple attempts to improve their dissemination and implementation, major gaps in knowledge and insufficient adherence to guidelines still remain a challenge. Second, this French multicenter survey confirmed and emphasized that awareness and follow-up of CIED infection prevention recommendations remain unclear, perhaps not fully implemented in real-world practice. Third, for example, assessing patient infection risk using the Prevention of Arrhythmia Device Infection Trial score and the antibiotic-eluting envelope use remains largely underutilized in clinical practice. The next paper is titled Patient-Initiated Transmissions and Remote Monitoring of Cardiac Implantable Electronic Devices, Evaluating Volume Clinical Value and Short Message Service-Based Strategy to Reduce Unnecessary Transmissions by Dr. Jaakko Hyvönen and colleagues. The first key finding is that patient-initiated transmissions accounted for 27.7% of all remote monitoring transmissions, but the majority, or 85%, were clinically non-actionable. Second, only 3.6% of symptom or unknown reason triggered transmissions resulted in an in-office visit. Third, implementation of a simple short message service intervention reduced asymptomatic patient-initiated transmissions by 31.2%. P-value equals 0.008. And finally, the SMS-based strategy improved remote monitoring efficiency without compromising patient safety. The title of the next paper is Initial Experience with the Extravascular Implantable Cardioverter Defibrillator in Pediatric Patients by Dr. Mark Walsh and colleagues. The first key finding is that the extravascular implantable cardioverter defibrillator, or EVICD, can be implanted safely in pediatric patients with good short-term outcomes. Second, the device is smaller and may be an option for patients where a subcutaneous device would be too large. Third, there are challenges with smaller patients who require a modification of the standard implantation techniques. And finally, longer-term follow-up is required to determine how the devices will perform with patient growth. The title of the next paper is In-Hospital Outcomes of Catheter Ablation for Ventricular Tachycardia in Patients with Prior Coronary Artery Bypass Grafting by Dr. Muhammad Isa and colleagues. The first key finding is that in a large national cohort, prior coronary artery bypass graft was not associated with increased in-hospital mortality or major procedural complications following ventricular tachycardia ablation. The second key finding is that patients with prior CABG experienced significantly higher rates of acute myocardial infarction and cardiac arrest, but markedly lower rates of pericardial complications. Third, in a dedicated subgroup of patients with coronary artery disease, the association between CAMH and acute MI was attenuated and trended toward a similar direction. Finally, these findings suggest that VT ablation can be performed safely in patients post-CABG, and that prior revascularization may increase peri-procedural ischemic risk. The title of the next paper is Myocardial Fibrosis Predicts Sudden Cardiac Death in Patients with Hypertrophic Cardiomyopathy After Cardiac Electronic Device Implantation. Insights from Cardiovascular Magnetic Resonance Imaging by Dr. Bing-Hee Fu and colleagues. The first key finding is that myocardial fibrosis in the inferior wall, transmural pattern, total fibrosis, and gray zone fibrosis were all significantly associated with sudden cardiac death risk. Second, incorporating transmural fibrosis and the percentage of gray zone fibrosis of equal to or greater than 21% into existing hypertrophic cardiomyopathy HCM SCD risk models significantly improved the predictive performance. Third, these findings support the clinical application of cardiovascular magnetic resonance-based fibrosis analysis in optimizing sudden cardiac death risk assessment for patients with hypertrophic cardiomyopathy. The title of the next paper is Body Surface Potential Mapping of Ventricular Depolarization and Repolarization in Phospholamban and Plakophilin 2 Cardiomyopathy by Dr. Iris van der Scheef and colleagues. The first key finding is that abnormal R, S, and T wave amplitudes were detected within and beyond the 12-lead configuration in pathogenic variant carriers associated with arrhythmogenic cardiomyopathy. Second, abnormalities were also detected in pre-symptomatic variant carriers, typically occurring outside standard precordial lead positions. And third, findings of follow-up body surface potential mapping suggest that these abnormalities are associated with disease progression. The title on the next paper is Causality of Atrial Fibrillation in Left Atrial Traits, Genetic and Epigenetic Perspectives by Dr. Di-Hui Kai and colleagues. The first key finding is that a bidirectional causal link exists between atrial fibrillation and left atrial function. AF causes detrimental changes in left atrial structure and function, and conversely, impaired left atrial active emptying fraction, which is abbreviated as capital LA, and then small a for active, and then EF. So LAAEF is the abbreviation that the authors use. This is a causal risk factor for developing AF, highlighting a vicious cycle of atrial remodeling. Left atrial function is a key mediator of cardiovascular risk. Specific left atrial traits were found to be causally linked to major AF-related complications. Reduced LAAEF and increased left atrial minimum volume increased the risk of heart failure, whereas LAAEF, left atrial passive emptying fraction, and Lamin are all causally associated with increased risk of embolic stroke or CES, independent of AF itself. Third, epigenetic mechanisms underlying the AF atrial trait relationship. The study identifies specific DNA methylation sites, and those are listed in the paper, associated with AF that are also causally influenced to left atrial traits. This provides a novel mechanistic link, suggesting that epigenetic modifications can drive the atrial remodeling observed in patients with AF. And finally, LAAEF is the most critical parameter among all measured left atrial traits. LAAEF emerged as the most pivotal. It is the only trait with a bidirectional causal relationship with AF and a key determinant of adverse outcomes, heart failure as well as cardioembolic stroke, positioning it as a crucial biomarker for monitoring, risk stratification, and managing AF and its complications. The next paper is published in our Global Voices section. The title is First Catheter Ablation in Fiji, Innovative Use of a Pacemaker Programmer as a Recording System by Dr. Bridget McElraith and colleagues. The first key finding is that these cases describe the first ever catheter ablation procedures undertaken in Fiji. Second, the innovative use of a pacemaker programmer substituted for a dedicated electrophysiology recording system demonstrates the feasibility of adapting existing cardiac device technology in resource-limited settings. Third, this workflow establishes a model for expanding electrophysiology access in underserved areas. The next paper is a topic review paper. The title is Cardiac Lead Perforation Mechanisms, Detection and Therapeutic Approaches by Dr. Amir Al-Washra and colleagues. This paper goes over the following key findings. First, cardiac lead perforation is a rare but serious complication of cardiac implantable electronic device implantation, influenced by factors such as lead type, implant site, age, sex, and body mass index. Diagnosis requires high clinical suspicion. Computed tomography imaging provides the best accuracy for identification of perforation and the lead position. Next, management depends on patient stability, ranging from monitoring in asymptomatic cases to urgent lead extraction in unstable patients. Next, active fixation leads and apical placement increase perforation risk, whereas septal placement and passive leads are safer for higher risk patients. Finally, there is a need for standardized diagnostic criteria, multi-center registries, and machine learning models to improve detection and guide management. The next patient is also a topics and review paper. The title is Pulsed Field Ablation for Ventricular Arrhythmias, From Mechanistic Foundations to Clinical Translation by Dr. Hongzi Li and colleagues. First finding is that mechanistic advantage using pulsed field ablation offers non-thermal myocardium selective lesion formation that penetrates scarred ventricular tissue more effectively than radiofrequency ablation, with reduced collateral injury risk to adjacent structures. Second, regarding emerging clinical potential, early clinical studies demonstrate favorable safety and acute success for premature ventricular contraction ablation, while scar-related ventricular tachycardia remains challenged by recurrence, highlighting the need for parameter optimization and lesion durability enhancement. Finally, regarding technological evolution, novel PFA catheter platforms with diverse electrode configurations and integration with three-dimensional mapping systems are expanding procedural versatility, enabling targeted ablation in complex ventricular anatomies and guiding future clinical translation. The next paper is one of our Fellows Corner papers, and the title is Thrombosis Occurring During Transseptal Puncture with Electrocautery, a Case Report by Dr. Zhang Hong Fu and colleagues. The learning points from this case that the authors provide are that first, this case first documented thrombosis during electrocautery-assisted transseptal puncture, highlighting a previously unreported procedural risk. Second, intracardiac echocardiography, or ICE, enables immediate thrombosis detection, underscoring its critical role in procedural safety. And finally, prompt heparin administration led to thrombus dissolution and provided critical preventive insights for future clinical practice. The next paper is a research letter, Cardiac Resynchronization Therapy in Patients with Cancer, a Single Cancer Center Experience by Nicholas King and colleagues. The first key finding is that cardiac resynchronization therapy implantation in patients with cancer is safe with a low risk of procedure-related complications comparable with the general population. 2. CRT in patients with cancer resulted in a significant improvement in NYHA class and objective improvement in left ventricular ejection fraction and left ventricular and left atrial volumes. And finally, active but potentially treatable malignancy with reasonable prognosis should not preclude therapies such as CRT, which improves symptoms and quality of life. Up next is another research letter. The title is Pulsed Field Ablation, the Pitfall of Remote Stunning, or the Importance of Contact and Contiguity. The first key finding is that in pulsed field ablation, remote stunning at a distance from the ablating electrodes should be considered. Second, in pulmonary vein isolation using pulsed field ablation, acute isolation does not automatically predict durable pulmonary vein isolation. And finally, precise control of contact and contiguity of ablation electrodes seems to be more reliable to predict durable pulmonary vein isolation. The next paper, which is the last one in the January issue, has a title of Life-Threatening Events in Patients with LongQT3 On and Off Beta Blockers, Insights from a Case Series, and this is a research letter. The first author is Alexis Hermida and colleagues. The first key finding is that patients presenting with arrhythmic events at birth had a very poor prognosis. Second, arguments used by physicians to support the decision to implant an ICD for primary prevention effectively identified patients who subsequently benefited. Finally, data do not clearly link genetics to life-threatening event occurrence. Thank you, everybody, for listening to the January 2026 podcast. Please join us again in February for the February issue podcast. And thank you, as always, for being a reader of Heart Rhythm 02.